Hi, my name is Ian Scott. I'm Director of Internal Medicine and Clinical Epidemiology at Princess Alexandra Hospital in Brisbane. And today I'm talking about consumer harm from low-value care. How bad is it? Low-value care, as we know, is often perceived as being well worth a go, better to be safe than sorry. Clinicians and consumers often don't find reference to cost or waste necessarily persuasive arguments, and often can misinterpret it as rationing. So I think we need to reframe low-value care in terms of its negative health consequences that can arise either directly from an episode of low-value care or indirectly from the cascade interventions following that index episode. So we looked at the literature on this between 2000 and 2020, trying to gauge the magnitude of low-value care-related harm, searching PubMed and Google Scholar using appropriate terms, as well as looking at our own personal files, and using the schema that Brownlee and Korenstein recently introduced in BMJ. So what did we find? Well, looking at the Australian data, there were 7 low-value procedures investigated in 225 Australian hospitals involving about 9,000 patients, and these were some of the procedures that were looked at. And what they found was that in between 2 in 1,000 to as many as 1 in 7 patients, depending on the procedure, developed 1 or more hospital-acquired complications, most commonly infections, but also other things such as pain and delirium and pressure sores. Amongst patients who had early MRI imaging for new onset non-specific low back pain, compared to those who didn't receive such imaging, they suffered more surgery, greater opioid use, and worse pain scores. Patients who have incidentally detected lung nodules on chest x-rays and then subjected to over-investigation with CT scans and biopsies, they also suffered more procedure-related adverse events, an 8% absolute increase, and more radiation exposure, with no difference in actual outcomes in terms of advanced cancer onset. Overprescribing of antibiotics in hospitalised patients is a major problem, and in this study of 1,500 patients, about 1 in 5 received non-indicated antibiotics, of whom then 1 in 5 suffered antibiotic-induced adverse events, including serious Clostridium difficile infections. And also, internists, 373 US internists, were asked, have you seen any care cascades following incidental findings in your practice in recent weeks? And they felt that yes, in many cases there was, at least of these index tests, about a third of respondents thought that that index test wasn't indicated, but it led to new invasive tests in about 3/4, emergency visits in half, and hospitalizations in half as well, with associated physical harms, psychological harms, financial loss, social disruptions, and dissatisfaction. So I think this is not an inconsequential problem, and we need to, I think, have more in-depth systematic understanding of the scale of preventable harms from overuse, and perhaps that in turn may then better motivate clinicians, managers, and healthcare managers to take this problem more seriously. Overuse is a source of preventable harm and therefore be considered a patient safety factor. So how can we identify instances of low-value care causing harm? Well, perhaps directly, looking at databases for instances of overuse and downstream adverse events, using discharge coding around narrow and broad definitions of low-value services, and trigger tools associated with overuse, as well as looking at patients who have hospital-acquired complications and where mortality and morbidity reviews suggest suboptimal care. Indirectly, we could look at risk-adjusted peer benchmarking in relation to rates of overuse of services, adverse events, and utilisation. It needs to be borne in mind that overuse can be difficult to define amid the many situations in which it can occur, and we need to just be mindful that there's very rare instances where care is rarely warranted, such as knee arthroscopy, and in many other situations overuse may occur with situations where that intervention could be useful in many people. So in all this, we need to have conversations around low-value care that requires humility, unlearning, and substitutes, but being aware and making our patients aware that low-value care can lead to preventable harm. Thanks for listening.